So welcome to everybody listening to the webinar, and we'll get started. So today we've got a wide range of people with expertise joining us. We've got Dr. Anne Kelly, who's a consultant in paediatric hemostasis and thrombosis from Great Ormond Street. Dr. Anne Kelly also works for SHOT as a member of our working expert group. We've got Rachel Moss, who's a senior transfusion practitioner from Great Ormond Street, and Tracy Shackleton, who's a blood transfusion specialist from Alderhay. We're also really honoured to be joined today by a patient representative. So we've got Cordelia, Cordelia. We've got Cordelia Okpua, who's a parent representative. Cordelia will be available for questioning, but unfortunately we've got a patient representative who is Ava, who won't be available for questioning at the end of today. So Ava is a patient representative and member of the Young People's Forum at Great Ormond Street. We've also got Michelle Scott joining us, who's a blood bank service lead at Sheffield Children's Hospital, and Dr. Paula Maggs, Dr. Paula Bolton, excuse me, Paula, who's been part of SHOT for many years, and she's part of the steering group now. Lovely. So what format are we going to follow? Well, I'll go through that. I apologise. I've got to thank you all. So it goes without saying, thank all of you for reporting, for your vigilance, for looking after your patients, and for really helping to keep people safe by participating in SHOT, and for joining us today. So the format we're going through today, we've just gone over what the session is going to involve. We're going to cover aspects of patient identification with some cases, then have the parent and patient perspective, a bit about what the transfusion laboratory can contribute, and then go through our normal 10 to 15 minutes Q&A at the end. So I'm going to pass over to Dr. Anne Kelly now, who's going to do the first half of the webinar.
Thank you very much, Victoria. That's great. So what we wanted to do is start off to highlight some of the challenges that we think are specific to paediatrics and neonates. And there's a little bit of overlap with adults, but there are some things about our patient group which can make patient identification much more challenging. So if we think about this, there are some practical things that make it difficult, in particular wristbands, and we'll talk more about these later in the webinar. They're often uncomfortable, poorly tolerated, and then there can be specific issues, particularly in neonates, preterm neonates, or any child with problems with skin integrity. So that's a specific issue. There are also other things around our patients. So we know that some patients, in particular babies, can have a very similar appearance. You know, as mothers, we all think that our children are very individual, but actually when you have a neonatal unit with a cot set up with very similar cots all next to each other, there is more potential for mix-up of the children. Many of our children, young children, are unable to communicate, so they're not able to positively identify themselves. And we have the added complication that of all patient groups, our children are more likely to change their names, particularly if they're children that have been looked after from birth. So they might be registered on the system as baby or male infant, and then that then gets changed to what their name will be. And then you can have children that are part of a twin birth or a multiple birth, and that adds an extra layer of complexity as well. We then have things around the environment. So we can have units, and the classic example of this is the delivery unit, where we have both adult and paediatric patients being cared for in exactly the same place. And the example of this, which we'll talk about a bit later, is the potential for mix-up between maternal blood samples and cord blood samples from the baby. With regards to diagnosis, there are also issues, particularly around chronically transfused patients. And this is not specific to paediatrics because we obviously have chronically transfused patients in adults. But I think particularly for children, as teams, we can become very familiar with our patients. And potentially there may then be reduced checking of those patients because we know them so well, and a potential for errors in that way. Added into that, we have complex or more complex special requirements for blood products for children, particularly children under the age of 1. And when you're adding in an extra layer of complexity in terms of checking that you've got the right component for the child, that can also increase our chance of having errors around identification. With regards to the way units are set up and with regards to staffing, we can have children being looked after by non-paediatric trained staff. This is often in terms of medical staff. For example, a child might be on a paediatric ward but being looked after by, for example, ENT doctors. And so sometimes this can add an extra layer of risk to the transfusion process, probably more relevant to prescribing, but could also be relevant for other elements and indeed patient identification. So SHOT collects data on near miss reports, and these are really vital for us to be able to understand potential risks to patients. And one category that it collects data on is something that we call wrong blood in tube, or we call it WBIT for short. We can see common themes in WBIT reports every year. A lot of this clearly being around a failure to identify the patient correctly. But in many cases, this is due to failure to follow the correct process for the sampling, in particular, labeling samples away from the patient. So classically, a sample might be taken at the bedside and then the blood sample taken, for example, to a doctor's or nurse's station or into a prep room and labeled not adjacent to the patient. The other two examples that we see in maternity services in particular and on neonatal units, in maternity services, it's mix up between maternal and cord blood samples, and in both maternity and on neonatal units is mix up between twins and higher order births. Of note, a large majority of these errors, they're near miss because they are picked up due to a historical group being on the system. So sometimes that might be a historical group from the baby or from the mother. And also those that aren't picked up by that are then picked up by the 2 sample rule. So this is where we need to have 2 valid samples from a child of group before any product is issued. And one thing to note really is that 1/3 of cases of wrong blood in tube are from maternity departments. So this shows you some of the summary data of the wrong blood in tube data reported to SHOT from 2019 to 2022. And up the left side of the axis there, we've got the number of reports. And then you can see year by year, this is split by age of child involved. And the most striking thing you can see is the large prominence of reports in children under 28 days of age. So that's the red bars. We see a few reports in 28 days to 1 year. Those are the blue bars. And then a smaller number of reports in children between 1 and 16 years. That's the brownie coloured bar, and 16 to 18 years, which is the green bar. And reports are pretty constant year on year. This is now the data split by the age of child and looking at the different types of errors. So down the left side again, we've got the different age of child, and then we've got the number of reports across the bottom. And you can see that in terms of total numbers, the largest number is the blue, where it is the wrong patient. So there's a variety of reasons for this, and often it's a failure to follow the correct sampling procedures. But the thing that I want to highlight there is the particular issues that we see in the little children, which are the mix-up between the cord and the maternal samples, which is nearly 45 cases, and then the mix-up between twins or high order births, which is just over 25 cases. So what we'd like to do now is bring to you some of the cases from over the last few years of the SHOT report and highlight some of the errors that occurred, and then my colleagues Rachel and Tracy are then going to give us some learning points and some impact from these cases. So the first case that I'd like to highlight to you is where the incorrect results were viewed for a neonate. So this was a baby on a neonatal unit, been very stable. Hemoglobin had been running between 140 and 160, and this child was prescribed 10 mils per kilo of red cells. Following this red cell transfusion, the baby became hypertensive, desaturated, and had a blood gas done at this point of deterioration and was found to have a hemoglobin of 211. And what had happened, it transpired that actually the hemoglobin result on which the order of the red cells had been made had been from the wrong child, had been in fact from the child in the bed next door. This child required venesection and dilutional exchange to settle the situation down. And the root cause of this error was that the babies were being reviewed via an electronic record, and more than one set of babies' notes was open on the workstation at the same time. So the wrong set of notes was viewed, and then the blood was prescribed for the wrong child. So I'm now going to hand over to Rachel and to Tracy to analyse this in some more detail.
Thanks, Anne. So what we've done with all our cases is we're going to look at both the impact and the resolution. Of course, they're far more complex than the one slide would allow, but these are the things that we, when we look at this, really do believe impacted the child. And the first, without question, is the unnecessary venesection. Not a pleasant thing for anybody to go through. Obviously, there are the consequences of the high hemoglobin for such a small infant. We know there's a risk of the unnecessary orders required, because when the hemoglobin goes up that high, other things are going to be impacted. Can't underestimate the amount of distress it causes to staff when they realise these errors have happened. We've said on many occasions, staff don't come to work to make an error, but it does really impact. And then, of course, extra treatment. So all that has to be taken onto account. But without doubt, the discussion with the parents must have been by far the most difficult thing, to explain what they've done. So the resolution, I think we really felt that just understanding results, and that when looking, because they had the wrong child screen over, just understanding the triggers and what we're transfusing for, and both the nurse for understanding the most up-to-date hemoglobin, and the doctors to reference back as to why is this hemoglobin so low and what are the other factors. This is a huge risk with more than one patient being open on EPR. We know that it is one of those things, but awareness when you're toggling between patients, I'm sure many will have examples of when that might have happened. And just a small thing that could be looked at, which is when you have an electronic patient record, is there something that flags up the most recent full blood count on that patient? Now, that wouldn't happen if you're ordering it on the wrong patient, but you might, if you're going to order it and then you've looked at the wrong patient's results, that might trigger something. So we really felt that we just having a better understanding, but we know that there are many problems with this and people are busy, etc., etc. But this is what we thought would really resolve this issue.
That's brilliant. Thank you. So the second case that we'd like to highlight to you is another classic error report that we see. So this is a case of mixed up twins. So two twin babies, were transferred from the delivery unit to the ward. Both babies were bled at the same time, and the samples were mixed up, and each was labelled with the other twin's details. One twin was OD positive and one twin was OD negative. Unfortunately, the mistake was discovered at the point of the second sample.
So yes, similarly to Rachel, we've tried to look here at the impact and the resolution for these particular patients. The first thing really to say is anything to do with very young babies and newborns is that the parents are always very stressed at this time, certainly if patients are taken onto a neonatal unit, and the impact on the parents being told that there's been an error with the children can be absolutely huge at this point. The thing I think that's always disheartening in these situations as well is the fact that we have to go back in and re-bleed these patients. They're bled a lot anyway when they're on the neonatal unit, and to have to go in a situation like this and re-bleed a patient is not only distressing for the parents, it's also distressing for the staff involved as well. The most significant impact that, although didn't occur in this situation but could have potentially been, is that if we'd actually transfused the baby that was group O negative with some O positive red cells and caused sensitization for that patient, sensitization can end up being a long-term problem for the patient, and certainly not something that you would want to introduce into a baby who is only a few days old. The final thing that we really felt was an impact, and I've already kind of alluded to it a little bit, is the fact that these patients are already getting a lot of samples taken in the first few days of life. Certainly, as I say, if they've got medical conditions that warrants them being assessed on a very frequent basis, is they can get iatrogenic anemia on the back of that, which is obviously a reduction in things like hemoglobin because we are taking so many samples off the patient, and again something that we really want to avoid. So in terms of the resolution, obviously the resolution in terms of twins is being very, very careful and making sure that any samples that are taken off twins where the only differentiator really is the twin or the triplet, or whatever that may be, is that the number which is assigned to that particular twin or triplet or sibling is really considered at the point, and that each one is done individually and very separately. Obviously, from this point of view, it demonstrates the need for the 2 sample rule that's been introduced, because it's only at this point that we can actually differentiate that and realise that the sample has been taken off the wrong patient.
That's great. Thank you, Tracy. So the next case that I'd like to highlight is one where we actually saw multiple errors. So in this case, what had happened was that there were 2 children. Child 2 had recently had their name changed on the electronic system by a ward clerk from baby to their name. The name was then similar to child 1. The first error occurred when child 1 was admitted to the ward, but no ID band was applied. A sample was then taken from child 1, who was on the ward, but it was labelled with the details of child 2, whose record had recently been therefore used, and the labelling of the sample occurred away from the bedside. Platelets were then ordered for child 1. Third error then, that the sample that was taken from child 1 was rejected as being too small. Fourth error, second sample was taken again and labelled again, but again with the wrong child's details at child 2. And this was only picked up when a confirmatory sample was requested to allow issue of the platelets to child 1, and the ward staff realised the labelling error at that point. So this really just shows the multiple different errors that can happen in the steps along the transfusion chain.
So this chains talk about multiple unnecessary repeat samples. I mean, it really is multiple unnecessary repeat samples, all for the want of completely mislabeling the child and giving them the wrong name. It caused a delay to the platelets because we just took so long in order for them to get it sorted, and huge anxiety for the family. If you come into hospital and are repeatedly bled because they keep making a mistake with the identity of your child, I don't think in any way that's reassuring to the parents about how the ward is operating. The 2 sample rule, we know that catches many faults, and this is one of those times where they picked up when they went to do the confirmatory sample that mistakes had happened. The culture of labelling the sample at the patient's side is an interesting one, because we all know when we talk about the sample circle that it is the right thing to do. But so many of these shock reports show that samples labelled away from the patient, and it's something as transfusion professionals we discuss often. I just want to focus on the wristband culture a little bit. When we've been doing wristband work in all our organisations, we know that the culture of wearing them and of positive patient identification is really led from the top. And a ward that has a culture of good patient identification and compliance with wristband wearing, and that might be a photo identity badge or whatever the process is, will then save a lot of these errors from happening, because it's part of the process to positively identify the child. And we know name errors happen. As we said, the first error from this is that we changed a patient's name, and then that they, and then that caused the error. So the resolution, focusing on the right patient, the wristband culture is an important part of that.
That's great, thank you. So the next case is another classic shock case. So this is a case of a mixed up cord and maternal sample. So the sample was taken at the same time as the mother's sample for the Kleihauer and for the cord blood for the baby. They were labelled at the same time, but the maternal details were put onto the baby's sample and vice versa. When the samples went to the laboratory, this was picked up because the mother had had a previous blood group sample on the electronic system, so they picked up that they weren't the same. And then they confirmed this by doing an alkaline denaturation test, which confirms that if there are fetal cells in the sample, that they'll be resistant to the alkaline in the test. So they were able to show that this was definitely a case where the 2 different samples had been mixed up.
So yeah, the impact on this can be quite significant, and from personal experience, this is a fairly regular occurrence that this happens. And I think we've already spoken about the fact that when we have parenting child in close proximity, there is always a risk for that happening. So the impact for this was obviously that the mother would have to be recalled. Often mothers are discharged very quickly postpartum, and for a lot of these mothers, having to get them back in to repeat this blood can be quite a difficult process. Obviously they've gone home, they've got a new baby, and we're asking them to come back in and have bloods retaken. For them, it's quite important, because obviously if this this has happened and there has been any breach of fetal cells into mum, we have to be sure within 72 hours that we have stopped mum getting sensitized in terms of any de-antigens coming over from baby. And we do only have that 72-hour window to do that. So as I say, it can be quite difficult when that initial mistake's been done, that we can get that mum back in and obviously make sure she gets the right treatment in time. Ultimately, again, if the wrong group is recorded on the mum's sample when actually it was the baby's blood in the tube, we can, sorry, the other way around, we can ultimately end up giving the baby the incorrect blood transfusion, which could obviously be extremely significant for the patient. The other thing obviously to note in this situation is that the surname is most often the same for baby and mum, and again this just adds to the issues in terms of separate identification. The resolution on this, although some units I believe do use different types of bottle when they're taking mum's sample versus taking the baby's sample, we also felt that maybe different coloured bottles would help in identifying them as being separate samples of adult and fetal blood. And the clear process of taking cord blood first and labelling it must really be put into place. The national guidelines on this say that actually mother's sample should be taken 30 to 45 minutes after the cord sample has been taken. So if this is followed and people are following this guideline to the letter as they should be, then again this would help with this process rather than being them both being taken at the same time.
That's great. Thank you, Tracy. So case 5 is an example of a failure to follow the correct procedure. And this is something that we see quite frequently in reports to SHOT. So in this case, it was a case from a child, and a sample was taken from the patient, and the member of staff left the bed space with the sample, and on their way out from the bed space picked up the wrong set of patient notes from a trolley and labelled the sample in the treatment room with the patient set of notes that they picked up, so therefore with the wrong patient details. Now, fortunately, this error was picked up due to the presence on the system of a historical group for that patient, so which obviously then didn't match, and they were able to work out that an error had occurred.
So I'm hoping by now everybody has started to think I'm just repeating myself, because we see that with all these errors, the same themes and impacts are coming up, which means that if we know what's happening, then hopefully we can work towards reducing them. So we know we've now got the incorrect blood group for the child, and actually it was picked up because we had that historical sample. Rebleeding children is a recurrent theme in this talk, because it's bad enough being rebled as an adult, but much harder if you're very small and scared. Delaying transfusion, we've already mentioned that. And then, of course, going back to the family and discussing why the error happened and how this mix-up became about, picking up the wrong notes. Going back to that sample circle again about never leaving the patient's side when you have that sample, so that you know when you fill in the label bottle, the bottle on the label on the bottle, you've got the right one. Now, I know that bedside tracking with on-demand labels can bring another selection of problems, but it is one resolution to keeping people in the bed space, because there are systems on the market whereby there is a wristband scan. It cannot be overridden, and there is a timeout feature. So if you wander off, you have to restart the whole process. And that does have a huge patient safety impact, although, as I say, it's not foolproof. And then, of course, we keep going back to the historical blood group, this repeat sample, because every time we've picked up these errors, we've picked them up because either we've had a historical blood group or we've requested another blood group, and that's picked up the error.
So the final case, which is probably my favourite case, we've called this Cheeky Boys. So this is a case of two boys, two 7-year-old boys in beds next to each other on an orthopaedic surgery ward. When the phlebotomist came to take some pre-op samples on the patients had not only swapped beds, they'd also swapped wristbands. One of the boys, who did not require a group and screen sample as he was not going for surgery, was bled, and a sample was sent to the laboratory. A second sample was then taken from the correct patient later on, and the fact that the two samples didn't match picked up that there had been a wrong blood in tube incident. And on investigation, the boys confessed that they'd swapped beds. And of note, this wasn't the first time that they'd done this. So I wonder how many other times things had been mixed up.
So, yeah, I'm hoping this isn't a trend, and I don't think this is something that we can necessarily account for. I think it does highlight some of the issues of dealing with younger patients, not necessarily the neonates, not necessarily the older child, but this in-between group where there is a lack of understanding of the importance of some of the tests and some of the things that we do within the hospital environment. So again, as Rachel said, the theme is that a patient was bled unnecessarily. Why he allowed somebody to take blood off him, I don't know, but I'm assuming, you know, he obviously just thought that that was a necessary test and really didn't put two and two together. As I've already said, you know, risk of children misidentifying themselves for fun. We can't do anything about that from the point of view of what these two children did. As I say, it was a kind of a unique situation, but it happened, and it was a real live case. So how we get children to understand the importance of that, you know, is obviously something that needs to be taken on board. Obviously, we had the whole thing again of the wrong patient's blood group being put on a patient's record, that then had to be revoked from that record once we realised that the first sample had been taken off the incorrect patient. And I think the thing that really highlighted for me in this particular case was the fact that the staff were really quite appalled at the fact that that could happen, and they were kind of felt very duped by the whole situation, and upset, I think, that had happened, and they hadn't realised that had happened. Again, it demonstrates the need for the two samples. Obviously, you know, in this case, that was the way it got picked up. The right child got bled eventually, and then obviously we realised that that was the case. We've obviously said, you know, in previous slides that consider photo ID badges. Whether these two children would have swapped their photos, I don't know, but bearing in mind everything else they'd done, there was every chance that that could have still potentially been the case. And one thing I always try and get across to the staff when they're bleeding patients, or is try and use the parents as much as possible, who are going to be the much more sensible people in these scenarios, and obviously try and ask them for you know, their child's identification rather than asking the child themselves, because often this information can be wrong, certainly in the younger child.
Thank you for allowing me to join this panel. My name is Cordelia. I'm a mom to a son who has required lots and lots of blood transfusion, and I was very, very happy with the checks and how the transfusion went. Firstly, when my son comes in, he always have 2 wristbands on his arm or sometimes on his leg. And when the blood comes, it is always checked by two nurses. Two nurses check his wristband, check the bloods, and check that he's the right patient before transfusion starts. And at some point, my son needed to have reedited blood. And it was when the nurses were checking it, it was always said out loud, and it was always told my son, you are having reedited blood. And it was always checked correctly. It is wristband against the blood type, how long the blood would be for. All of this was always mentioned to myself and my son. So it just goes to show that it is very, very important that we have the right patient and the right blood. And there was an incident when my son had a reedited blood. He developed headache. I was very, very relaxed. I wasn't worried because I was well assured that he got the right blood. This is because the nurses checked the blood type, explained to us that it was reedited blood, and even when the headache was just persistent because it just came on suddenly, I didn't panic. I did not panic at all because I know he got the right blood. So until it was explained to us that it was because of some of the products in the reedited blood and it could lead to headache, and he was fine afterwards. So I'm really very, very happy with the identity checks before blood is transfused. It just gives us that assurance that our child is getting the right blood, and if anything goes wrong, it is not because it wasn't checked properly, it's just because of any other thing. So I would really propose that two wristband checked by two registered nurses, read out the blood type, the blood group. And there was an incident as well where my son now knows his blood group. So when they say O positive, it's like, yes, it's O positive. Yes, so that's it really.
So we'd like to thank you so much, Cordelia, for sharing your perspective. That's really valuable. And we'd also like to say that Cordelia's son is doing really well and that headache all settled. We think it was probably some citrate toxicity. We'd now like to hear from Ava, who's a patient representative.
So hi Ava, my name is Liz. I'm a nurse at Great Ormond Street and I'm here to talk to you about transfusions for the SHOT forum, which is the Serious Hazards of Transfusion. So if you could introduce yourself to me and your role within the Young People Forum and tell me a fun fact about you, please.
So my name's Ava. I'm a member of the YPF, also known as the Young People's Forum. And a fun fact about me is I have 2 cats.
That is a good fact. So the first thing I wanted to know about you is if you have any experiences of being identified in a hospital, so for medicines or x-rays, blood tests, anything like that.
Yeah, so I've been at hospital for like pretty much my whole life, ever since I was like maybe younger than 4. Yeah, way younger than 4. So my whole life. And I've had a bunch of x-rays in the past, a lot of blood tests, like you said, and I've gone into hospital for a lot of IVs as well. So especially when they do x-rays, they always check. But yeah, I've had a lot of experience with that.
Yeah, and you've been wearing a wristband every time?
No, I stopped wearing a wristband years ago because I'm actually slightly allergic to something on it, and it gives me like a rash and my hand gets a bit swollen. So they've done alternate methods for me.
What sort of methods have they used for you?
They've used like a photo card which has my information below it. That worked pretty well. It was just like a little slip of paper, but like a nice glossy one with photo. And that would just go like next to my bed. Surprised I didn't lose it now, but it worked pretty well. There wasn't any issue. I guess looking back, it maybe was a little bit, some people might have been uncomfortable with that because of like privacy. Everyone can see your information and your photo. Personally, it wasn't an issue for me because also I was pretty young and didn't really care. But yeah, it worked pretty well for me.
Do you think if you hadn't been allergic to the wristband, that would have been a fine option?
Yeah, I think if I wasn't allergic to the wristband, I mean, obviously it's still uncomfortable, and that's a big thing because you have to wear it all the time. I probably would have just worn it, but I think sometimes in the past my mum would attach it to my hospital bed with the wristband. So sometimes we did a photo, sometimes we just attached it to stuff, and that worked fine for me. But obviously, if a lot of people use it like that, it's obviously going to be some problems sometimes because it can't be always perfect. It's going to make mistakes and stuff. But yeah.
Perfect, thank you. Have you ever not been asked your name or your date of birth or something like that when you were going to have some medicine or an x-ray?
Yeah, so I'm sure it has happened where someone's forgotten to ask me, but my mum would have been with me, so she probably would have, like if it was the wrong thing, she would have known, because she would have known what we're going into. But it probably has happened. I can't remember any specific examples because, again, like there's bound to be some mistakes through the course of my life, so I'm sure there has been some errors. That's okay.
Thank you. Have you ever heard of a moment either with yourself or with somebody you know where there's been a mix-up between patients?
So yeah, it hasn't happened to me personally, but I've heard like some examples from people that I've spoken to where either some people looking at the name wristbands and being like, oh, this is you, and they said, no, it's not me, and even though it was them saying, actually, it's not me, they were saying it is you, and it wasn't, which is ridiculous. And sometimes people would just get the wrong information and stuff like that.
Yeah, it's quite a worry. I think it's great that it hasn't happened to you, but it's a worry that has happened at all, and that there's been a weird conversation about, no, it is. That's odd. So in blood transfusions in particular, there's lots of training for doctors, for nurses, about making sure we get the right blood into the right person and taking blood from the right people. Wristbands or patient ID is really important for this. So what I want to know, and I'm hoping you've had a chat to some of your YPF friends about this, is what do you all really think about wristbands?
So we've had a lot of points to bring up about wristbands. Some people are saying, like, just as an example, they might be a bit bland for maybe younger patients and they wouldn't really want to wear it. Obviously, it's itchy, it's scratchy. It's generally not a very positive experience to wear. Like some people are saying with allergies, like it's a big red band. I personally haven't had that because I don't really have allergies like that. But yeah. And they're saying, oh, it's a bit embarrassing, it's a bit awkward. It's like it's a huge thing, but it may be like a little symbol instead of not an entirely red band that makes them quite embarrassed, they said. And there was a bunch of other different points, and we were talking about alternatives like QR codes, possibly badges, and all those kind of things.
Yeah, I think there's bound to be good ideas out there that we just haven't thought of yet.
Yeah, and biometrics.
And biometrics, absolutely.
Yeah.
Do you understand why we are focused on wristbands?
I think focusing on wristbands because like it's a really important thing that you get people's information right, and it's like quite important for privacy and to make sure that there's no like switch ups between people so that people get the right medication and whatever they need, and so that's the other person doesn't get the wrong thing.
Yeah. No, that's exactly it. So making sure the right people get the right things. Do you think there's anything that we could do, and you touched on it a bit earlier, to improve wearing wristbands?
I think to improve wearing wristbands, we need to fix how uncomfortable they are. So we need to make them a little bit softer, maybe different material, but we should definitely make them less scratchy and make sure that we can have different sizes, so that they're more flexible to put on people. Like if there's a very small wrist and maybe the information overlaps onto the side of where it sticks back on, that could be kind of bad. Because obviously there's no point, like you can't see the information if it's a very small wrist, like a baby for example. Or if it's too big and it gets lost. So just making sure you've got different sizing and it's comfortable to wear.
Yeah, perfect. Do you have any completely different ideas than a wristband that you've thought about?
Yes, personally, now this is just my opinion, I think that biometrics is probably the way to go, since we're entering like a more like technological age, and it's like technology is becoming like more and more apparent, and I think it would be useful to include that in that, because with technology, like you can't, if you're gonna like, for example, scan a QR code, like all the information will go onto the device, and then it means that not only can people looking at the thing not see all the information, which is for like privacy, but it's also quite helpful in case like something isn't like fully like legible or a little bit small, and then the phone will do its thing.
Fab. Thank you so much, Ava. This has been incredibly helpful.
Thanks.
Hello, I'm Michelle Scott from the Sheffield Children's Hospital. My camera's been stopped by the host, so if somebody can start my camera, please. Thank you. So this screen is intended to be quite confusing and messy, because this is just to let everybody know how much information there is there regarding guidelines. There we are, sorry about that. Recommendations, safety alerts and SHOT. So if we go on to the next slide, please. So in the laboratory, we are really good at following rules, following guidelines, following policies and procedures. So we expect that when the sample gets to us, that happens also. So we expect that patients are positively identified according to national guidelines and local policy, that the sample is labelled at the bedside or next to the patient by the person taking the sample, and for the sample to be clearly and correctly labelled with all the required patient identification. Simple, right? Not necessarily, otherwise we wouldn't be here today having this talk. So this is just an example of some samples that were received, that were found on the ward, fortunately by laboratory members of staff, so we were able to quickly dispose of them and report them. So these samples were obviously not taken at the bedside, they were just found lying around on the ward, which is really dangerous. So proper patient identification and correct sample labelling is a critical point in the transfusion process, and it does lead to incidents which we see in SHOT reports. And equally important is not to pre-label samples, as this is equally dangerous. So what is acceptable? So it's clear in the guidelines that we need to have samples labelled with the core patient identifiers, first name, last name, date of birth and unique identifier, which could be the hospital number or NHS number, date and time the sample was taken, and the initials of the person taking the sample. So we need to have a zero tolerance approach to this, but there can be circumstances where it's unclear whether samples are acceptable or not, which I'll go on to next. And we all need to have a process and policy in place to deal with samples that don't meet the minimum requirements. Next slide, please. So what to reject? So these examples are pretty clear. So if a sample's labelled with the wrong name, the wrong date of birth, the wrong hospital number, straight in the bin, no question. We would also reject samples that are spelled with a name with a different spelling, because we see that as a different name. They would also go in the bin. Quite a common error that we see is samples are labelled with the current year rather than the year of birth, because people are used to labelling things with, signing things with the current year. Smudged, illegible information on samples. If you can't see what is on the sample, then you can't confirm it's from the right patient. And also anything that's clearly crossed through and an alternate detail is written on, straight in the bin. So they're simple. But what about a slight smudge? So we've got an example in the top right hand corner. So you can see that the details are there-ish, but it's not clear, it's not legible. Would you accept it? Extra long names. So we're seeing patients now with double, triple barreled, really long names. And it's literally impossible to fit all that information on these teeny tiny paediatric samples. I think individual laboratories need to have an acceptance policy on these types of situations to prevent patients being unnecessarily rebled. If there's no signature or date bled on the sample, if there's more important information on there, like the name and date of birth, and there's literally no room left, is it acceptable to accept that sample if that information is on the request form? Poor handwriting, so we see examples of this all the time. Again, it's not clear, it's not legible, but if you can just about make it out, is it acceptable? And also particularly in relation to little babies who have frequent name changes sometimes, if the information on the sample is correct, but the request form information is a little bit outdated and it's got the previous name on, is it acceptable to accept those samples? And then there's certain letters and numbers that look the same, such as EC17. If you can make it out to what it's supposed to be, is it acceptable? I attended the BGS blood serology Nottingham last year, and there was a really good talk on this. And even amongst a full room of experts, there were certain examples where we couldn't reach a consensus regarding what was acceptable and what was not. So these little differences, it is a bit of a problem. Next slide, please. So what are the consequences of poor sample labelling and poor patient identification? So basically samples need to be retaken. And we've already said that it's not a very nice experience for patients. The little ones, they're in unfamiliar surroundings, they're being poked and prodded. Not ideal if it's not necessary. It can result in upset and angry parents. You might get a grumpy doctor on the other end of the phone if they've got to approach the parents again and the patients get extra samples. Little fact in the top right hand corner about phlebotomy associated anemia and the impact of taking a really small sample from a really small person. It results in extra work for both lab staff and ward staff. Potential delay to transfusion, which sometimes is shock reportable, which we should know, and it can result in a longer attendance in hospital if the sample needs to be retaken. That's a delay. In this group, I'm particularly thinking about transfusion dependents that attend every month, so they're already missing a significant amount of time from school. We don't want to make that any worse for them, really, if it's not necessary. Next slide, please. So despite all the clear guidance on patient identification and sample labelling, we still get wrong blood in tube incidents. And actually, of the wrong blood in tube examples I've seen, they are beautifully and perfectly labelled. So we have no idea that they are from the wrong person. Slide, please. Which is why the 2 sample rule has been implemented and advised across the country. So this came out in around 2012. And I'll be honest, we at the Children's only implemented it recently because historically our wrong blood in tube incident rate was really low, but that started to creep up, which made us revisit the risk assessment, and we've now thankfully introduced the 2 sample rule. Next one, please. So the 2 sample rule, I think in the examples that we've seen before, it is essential in reducing the risk of ABO incompatible transfusions. There is nothing described in the guidelines regarding the timing of samples, the time difference between the samples being taken. So I think it's up to individual trusts to make a risk-based judgment on what is appropriate. I think we also see examples in shock reports where samples have maybe been taken at the same time, but then kept in somebody's pocket and sent later. This is not acceptable practice. Logistics of obtaining a second sample. Some trusts adopt an approach where a specific second sample is only issued once the first sample has been received. But again, it's down to individual trusts to decide on how to tackle this. And this is not addressing the root cause. I think as incident investigators, we're all trained to identify the primary cause and correct that, but this is a control measure, but a necessary control measure to protect against ABO incompatible transfusions. So just a bit about how we identify unknown patients. Obviously, we don't know the name or date of birth, but we do need to make sure that they receive safe blood components. There was a safety alert issued by NHS Improvement, which guided on how to address this, which included naming patients with names from the phonetic alphabet and applying a date of birth of 0101 and the approximate year of birth, and using a unique identifier. Next one, please. So at the Sheffield Children's, what we've done is we've created a bank of unknown patients that we can just allocate to unknown patients as they walk through the door. So these are pre-registered patients with a hospital number, forename and surname from the phonetic alphabet, and then we would just apply a date of birth. So then they would retain that identity until it is safe to merge the patient to an existing record or to update the patient details with their known details. So other considerations, if we had more time, is how do we tackle name changes and patient merging? So any patient with transfusion records the record should be reviewed by a blood transfusion member of staff to make sure that we're not forcing a blood group onto somebody incorrectly. Separated samples, so we need to make sure that the separated sample is also labelled appropriately and adequately. Recall procedures, should we detect a wrong blooding tube, we need to make sure that we have procedures in place and that these are also tested to make sure they fit the purpose. It's not to be underestimated the time involved in investigating incorrect patient identification. It can cross different disciplines. It can involve different areas, the lab, the ward, the spot, and also incident reporting internally, externally. There is a lot of time and effort involved in investigating these. And also patient identification is important for other disciplines too. If you get incorrect hematology or chemistry results, that could result in incorrect treatment or management, and that is equally dangerous. So final thoughts. We see phlebotomy as a minor surgical procedure which should be kept to a minimum. We should ensure that there's a good incident reporting and patient safety culture. Zero tolerance, we shouldn't be pressured into accepting any poorly labelled samples, and we should understand the consequences. I think that's a really important thing, to instill that kind of safety culture in the workforce. That's all from me. Back over to Anne, I think.
Thank you, that's brilliant, Michelle. So I'd just like to highlight briefly some of the resources that are available to you, and you can always go back over this presentation to get the QR codes. So we have the annual SHOT report. There is also a SHOT app that you can download through which you can access the SHOT resources. Next slide, please. In terms of paediatric specific resources, we have the Paediatric SHOT Bite, which summarises learning messages for neonates and paediatrics. And there's also very there's a very useful SHOT video which summarises the last 10 years worth of SHOT data and the key learning points. Next slide, please. There's also prescribing resources out there for children. So the blood component apps, along with covering prescribing for adults, also covers infant children and neonates, and that's available to download. Next slide, please. And there are several different transfusion guidelines, including the main one, which is the 2016 one. There's an amendment to that from 2020. But there's lots of resources there which you can access online, or if you need pointing towards them, you can speak to your local transfusion practitioner. Next slide. So to summarise, this is an example of the sample circle. We need to label samples within this sample circle. Patient identification can be challenging in paediatrics, particularly in neonates, and the two-sample rule can pick up errors before clinical impact occurs. And as I've already said, we've got to label the samples next to the patient. And local transfusion policies should include guidance for the safe labelling of transfusion samples, including cord blood. Next slide, please. So in terms of key messages, don't assume anything, check at every step in patient care. Empower your patients and carers to be able to challenge and to know what their own transfusion requirements are. Treat each patient as an individual and listen to concerns from parents and carers and families. There should be a zero tolerance policy for samples. We need to label them correctly first time, every time. And remember, all of this information is important, not just for transfusion, but for medication and for other blood samples and other investigations for children. Next slide, please. So I'd like to thank the rest of the SHOT steering group and working expert group, particularly Helen New and Rebecca and Ruth Godstein, the MHRA Haemovigilance team, and all of the reporters and hospital staff who share their incidents and allow us to learn from them, and all colleagues in the transfusion community. Thank you.
On behalf of the SHOT team, I would like to thank all the speakers and presenters for their valuable contributions today. Given the time constraints that we're under, we'll move swiftly on to the Q&A session, and we'll try as hard as we can to get through some of these questions before the time runs out. Our first question comes from Claire O'Reilly, who says that her site recently introduced electronic patient identification for sample collection, and some parents have commented on the fact that their children's wrists and wristbands are constantly being scanned. Are there any cases where parents refuse to allow scanning wristbands worn by their children? Rachel, are you able to take that question for us, please?
Yeah, I'll take that.
Thank
I
you.
think whether the wristband is scanned or identified, I think it's a compliance with wristbands as a whole, because the barcodes are on there. And I think that's where sometimes alternatives are required. And we know that parents cut them off because they don't really like them. And you mentioned, so you heard Ava mention earlier that her mum put it on her cot because it was irritating her. So I think for me, my experience is not so much the scanning, it's the wristband themselves that they have an issue with.
Thank you, Rachel.
We have now another question. Should cord samples really be used for ABO grouping? The purpose of taking a cord sample is to ascertain if the mother needs NTD. Is there a standardized practice guidance on taking cord samples and labeling of cord samples? And for positive patient identification, that baby has just been born and the mother had just delivered. Someone wants to comment on this, please?
And whether you would be able to lead and start on this?
So I mean, yeah, I mean, I guess you want it for the CLI-HAL for the mother, but you also need to know what the group is of the baby, isn't it, in terms of knowing how to manage it. So yes, I think we do. And secondly, yeah, there is guidance there, and I think in one of Rachel and Tracy's slides, they alluded to that reference, and we can either try and share that now, or we'll make sure that's on the final somewhere on the resources attached to this webinar. Eventually we can put a link on there, can we, Shruti? Yep.
We will be uploading, I think there's already a document with all the useful resources, both for the adults as well as the children and neonates. So when we put up the webinar recording on the SHOT website, you will be having a document with all the useful links to guidelines and resources. Thank you.
Thank you, Shruti. Our last question for the day comes from Johannes Miller, who is asking why a wrong blood in tube error is not a disciplinary action. Paula, would you like to answer that question, please?
I wouldn't really, because I think it's the whole principle that we don't want people to not report things because they're frightened of the consequences. And it's terribly important that we're able to learn from the things that we don't do right. So to have a disciplinary action is not a useful way forward. And I hope that Shruti will comment on that too.
Yeah, thanks, Paula. I think, it is important we address the system errors, because I think although we say that an individual may have deviated and has a workaround, I think many of the situations may be because of the complex, place, whether they don't have, I'm not trying to provide excuses, but it is actually to understand and build our systems and the processes so that people are able to comply with it. And also the second thing is actually do staff understand the potential implications, because they may not really understand that they are not doing anything wrong long, but actually it's, you know, in sessions like this, where we are able to highlight through the cases submitted and also to understand the value that, okay, it could have actually resulted in a potentially fatal ABO incompatible transfusion. So it is staff understanding the why, and also actually then making sure that our systems are actually then allowing the right processes to take place. So I wouldn't, now there may be individual instances where there is a deliberate deviation, that is a different instance, but more often we are talking about errors that are happening because of bad systems in place.
Thank you, Shruti. I think we have time for one more question. Over to you then, please, Sai.
I can't hear you, Sai. I think you're on mute.
I think that Sai is having problems with his microphone. I'm quite happily just get the last question, if that's okay.
Great, thank you,
so
Vicky.
somebody's the little question about group and safe forms, and do we think they're always going to have to be handwritten? And I suppose we can discuss whether we think that that's a positive thing for patient safety or not.
I can pick that one up if you want, Victoria.
Thank you.
I think a lot of it depends on how you work in your organisation. There are many organisations that group and safe request forms aren't handwritten and they're printed from a system, and there are organisations, including my own, where we no longer need a group and form request form, and actually we generate it in the laboratory because we find it's a much safer and less stressful system for both laboratory and clinicians. So I think there's definitely a time when we can move away from group and safe request forms being handwritten, without a doubt.
Thank you, Rachel. And thank you all for those great questions. Apologies that we haven't been able to get through them all during the session, but if you do have any burning questions, please do send them through to the SHOT email address. In these last few minutes, we're going to go to a live poll, which should be appearing on your screens now. Please do submit your answers, as we really appreciate you taking a few minutes to complete this, as it helps us guide for our future sessions. While you're answering these questions, I would like to remind you that the session has been recorded and will be uploaded onto our website as soon as possible. We do really appreciate your feedback, comments and suggestions about hemovigilance and the work that SHOT does. So please do get in touch with us either by phone or by email. Please do visit our website, www.shotuk.org, to see our reports and resources. They are freely available for you to help you with your transfusion educational activities. As I mentioned earlier, SHOT now has an app which you can download. Put SHOT UK in the search button to find your app. Finally, a huge thank you to all our speakers and presenters today for a very informative session, and to all of you for joining us. We hope to see you again very soon. Thank you and goodbye.